Good evening, friends. Welcome to this Tuesday evening master classes. This has been a phenomenon for last 5 years or so by all our senior faculty, teachers, and guide. And this has been a platform to actually give students an opportunity to get exposed to this kind of interactions with the so-called seasoned teachers, faculty, so that they get a hint of a feel of the examination before they actually appear real one. And today we picked up a topic called traumatic brain injury, and for that we have a couple of our students who are DRNB fellows and IDCSM fellows from Yashoda Hospital, Somajiguda, Dr. Karthik and Dr. Kiran. Welcome both of you.
Good evening. Good evening to you.
And we have been very fortunate and we are privileged to actually today have Dr. Kusra Bhajan sir, who have been a part of this academic faculties for a couple of decades or more since our days of learning till today, and being a very good teacher, orator, and been an academician throughout from Hinduja Hospital, guiding, teaching many students in the different platforms. Welcome you on board, sir. Thank you for accepting our invitation and being a part of this program.
My pleasure. Thank you. Thank you.
And we have another young dynamic colleague of us who has been with us in Hyderabad. We had a good time parallelly happening to have. I still remember Dr. Safi was earlier part of our teaching career, was appearing his early part of FNB exams and all that. And he has grown up from there to be a part of consultant in the Department of Critical Care Medicine in Apollo Hospitals here, and moved to Riyadh now as a consultant there in the Department of Critical Care Medicine. Maybe more than 5 years or so, Safi, there?
Yeah, no, I'm in Riyadh for more than 4 years almost. Thank you, Venkat sir. Thank you for inviting me.
Yeah. I came across your details from your good friend Karthik, being in the forefront of many research and academic fronts. And it will be a very value added to us to add your side of experience in the traumatic brain injury from Riyadh itself. So
pleasure is mine.
Over to both of you for the case and flow. Then we will probably take at the end some questions from that. So all the participants who are there, this is again an announcement that you will be a part of it. You can actually answer the questions in the different forum, and we'll take it forward. Thank you. Over to both of you.
So I think we can get started. Dr. Karthik and Kiran can present the case, and like the exam pattern, I think maybe we might interrupt you in between and ask a few questions unless they are really important, and then at the end we can summarize that. So over to you all, Karthik and Kiran.
Yeah. Good evening, everyone. Good evening, everyone.
Good evening.
Yeah, doctor. Please.
Like we are going to present a case on traumatic brain injury. So the case is like a 40-year-old male, and like he had a RTA around like 9 a.m. in the morning, and patient got received in the emergency department at Yashoda Somajiguda at around 9:40 a.m. So mechanism of injury will be like he had a skid and fall from two-wheeler, sustained injuries, multiple injuries to head, face, and the chest regions. So on examination, like he is having a nasal bleeding, bilateral nostril bleed, plus LOC was present, which is like not significant, which is told by the attenders and like bystanders. And there is no history of seizures or vomiting at the presentation of the patient. So on arrival, GCS is Glasgow Coma scale was around like 5/15, and like tachycardia was there, mild hypotension with respirator of 10. So patient got intubated in the ER in view of low GCS. Started on mechanical ventilation. A saturation was found to be around 100% with mechanical ventilatory support in the ER. So next is like primary survey of the patient, which majorly contains.
1 minute. Yeah. So Karthik and Kiran, anyone can answer. So what do you understand when a patient like this comes to you? I mean, what are your things that you keep in mind, and what should you do immediately? So if you can go back to the previous slide.
Okay, sir.
Have you heard of the MIST criteria, the MIST in trauma? The MIST, that is mechanism, injury sustained. signs and symptoms, and then treatment and trends. So every patient of injury you might want to present as a missed criteria. So these are just we are going to walk each other through this, and Shafi will agree with me that whenever you have any injury or trauma, you must talk about the missed criteria. Okay. So the mechanism here was a two-wheeler. So what are the suspected injuries that you might have? Because these are the questions you will be asked later. So two-wheeler and he's fallen off and.
So maybe
usually the head injury, facial injuries, scalp injuries, and the chest injuries are suspected in a patient motor vehicle skid and fall from bike, and expected injuries will be a skull fracture if he is not wearing a helmet, and facial bone fractures, and maxillary and mandibular fractures, and there will be if there is a neck injury, there might be the major blood vessel injuries, and also chest trauma leading to any breathing difficulty, like if the patient is having any flyal chest or pneumothorax. So
Sure. So in this case, very rightly said, but so you did not only stick to traumatic brain injury because that's the topic for today. And you should be saying that it's a two-wheeler who wore a helmet or did not wear a helmet. So that's important. And if the helmet was worn, then probably the head injury could be avoided. And if the helmet was worn, the cervical spine can be more damaged. So I think a little gist there would have, enhanced your case. Very good. You have said there is LOC, there is nasal bleed. So there could be facial-maxillary injuries. And obviously, the Glasgow coma is 5. So it's always before presenting something, you should say that this is a case of severe head injury. And because the Glasgow coma is less than 8, we have intubated the patient, which is rightly so. Now, during this intubation, who did this intubation? You all probably did, right? So you will be asked, what are the precautions during intubation?
So all trauma patients, until and otherwise ruled out, we need to suspect a cervical spine injury, and we need to secure manual inline stabilization while performing any procedures or movements, patient transfers. So manual inline stabilization is done by the assistant standing at the head end and holding the head at the mastered process. The point is to keep the cervical and the lumbar spine aligned with each other to avoid extension or flexion or rotation movements, so that the patient does not land up in quadriplegia.
Sure, fair enough. And you would probably do an RSI.
Yes.
or rapid sequence
Okay.
Shafi,
Dr.
your
Kar-
comments?
Yeah. Yes, I wanted to specify regarding mechanism of injury. Since you explained that patient had a skid and fall from the bike. So what was exactly type of injury actually? What mechanism can you describe? The mechanism of injury in this case will be?
High speed vehicle.
Yeah, a deceleration injury primarily, right? Because then it will be reflecting to you what injuries actually he suffered later on. So the deceleration mechanism of injury is primarily associated with significant head trauma actually. So this is one. Second thing on arrival is GCS was 5. So can you describe exactly the components of the GCS in this? Exactly what was the motor, what was the eye opening?
Yeah, sir. Like eye opening was E1, sir, and E1, and he was around verbal response was like very incoherent sound. Will take 1 to 2, and motor component 2 to 3, sir. Like it was just there was like around only flexion to withdrawal of flexion to pain, sir. It was like it was
So it
around.
was flexion. Flexion means it was 3. Abnormal flexion.
Yeah, sir. Yeah.
So abnormal flexion 3 response in this patient. Or do you think is there any significance of this?
Maybe hypoxic ischemic injury.
Hypoxic ischemic injury, we are talking about, I think the patient might be having a raised ICP, right? Because he has an abnormal flexion and extension. Both the things will be counted as patient has raised ICP here. And since the GCS is 8 or less than 8, of course, in this case, so that means suggestive of that he has a severe traumatic injury, as Dr. Pushraf said already. So basically, that only shows that the severity of injury, as anything motor response of less than 4 is very serious, right? And it has important prognostic significance also that we will see later on, right?
Yes.
So you told me about something about the intubation and ventilation. So what are the steps you will take when intubating these patients? Manual inline stabilization. What other things to prevent ICP?
Pardon?
We didn't get the questions.
How will you intubate this patient? Dr. Shafi is asking you. So what are
We'll
your
be
steps?
intubating with rapid sequence induction, sir. Rapid
Very
sequence
good.
induction method. Yeah, sir. Like I'll be going with sedative opioids plus or minus like muscle relaxant, sir.
So you have done an inline immobilization,
Yeah, sir,
or the better now,
inline.
a better term now is spinal motion restriction.
Yeah,
That's
sir.
the newer guidelines. And what is the most important to avoid during intubation? You might take about 5 minutes or so. You may not be very slick. So what will harm the patient more?
Hypoxia.
So how will you prevent that? That's what Dr. Shafi is asking. What's the
So
first
will be
step
like
of your RSI?
Continuous
Pre-oxygenation,
support. Continuous oxygen support.
Pre-oxygenation with 100% FiO2.
Yeah. Also, you will not let hypotension set in because these two are the absolute evils in traumatic brain injury. Okay, you can proceed. Shafi, can we move on or?
Yeah, sir. We can move to the next slide.
Yeah.
So we did a primary survey, like which includes like ABCD approach, like in airway. During ER, the airway was protected with cooling off secretion, whether spine was secured with the heart collar, intubated for the airway protection with rapid sequence induction with inline manual stabilization. So coming to B component, breathing, bilateral symmetrical chest movements were there. R entry was equal on auscultation post intubation, and SpO was around 100% with ventilatory support.
Yeah. Just a request, never say hard collar. It's always a semi-rigid collar.
Okay, sir.
There is never a hard collar applied. It's always semi-rigid.
Okay.
Yeah.
So coming down to C part, circulation, pulse rate was around 112 by per minute, and like BP was around 160, and capillary refill time was less than 2 seconds, and peripheral pulses were all palpable and present, sir. So coming to D component was disability, which is like GCS, post intubation, like even BTM5 and bilateral pupils were equally reactive to light, and sugar was found to be eglycemic, sir.
So you have had a discrepancy here. You said 5 first and now it is 7. So, you know, when somebody comes with 5, it is like almost a dead case in traumatic brain injury. So I would have requested. That's why Dr. Shafi was asking you, how did you get the 5? Otherwise, we don't care. We know that you know the Glasgow coma. So it was written 5 in the first slide and 7 here. So you should be very, very careful about Glasgow coma. Why is it important? Because you know the severity. You need to see whether 7 has become 5 or 9 has become 7 and so on and so forth.
Okay. So E component like exposure, temperature was around 98, normothomia, bleeding was present, like multiple aberrations were there, no deformities, and chest and pelvic compression test was negative.
Okay, one question here. This and circulation, you said the blood pressure was 100 by 65. So was it before intubation or after intubation?
Sir, post intubation.
Okay, post intubation, right.
Yeah.
So in the pre-intubation, also your blood pressure was slightly on the borderline side, I think 106 by 7.
Yes,
so
sir.
Why do you think this patient who has a severe traumatic brain injury and high ICP, as the blood pressure is on the lower side? What's the significance of this?
Sir, any hemorrhagic shock might be related to the hypotension of this patient.
Very good. Very good.
That might be the first my first concern, sir, in a patient of any trauma and polytrauma, RT and polytrauma.
Okay.
So, maintaining MAP is more important in maintaining CPP, sir, which reflects your cerebral perfusion pressure. So MAP should be maintained like 60, more than 65, sir, 65 to 70 mm of mercury, sir. So that will be my priority to keep my MAP of around 65 to 70, sir.
Yeah, I mean, in the severe traumatic brain injury, you target MAP of 65, 70, or it is slightly different? It's not sepsis case. It's not septic shock.
Exactly.
Here our target of MAP is slightly higher, isn't it?
More than 80.
80, sir.
Yes, very good. So at least 80 on above should be our target, between 80 to 100. But ideally, we should talk in terms of PPP, which is cerebral perfusion pressure, and try to maintain 60 to
60 to 70 of cerebral perfusion pressure.
Exactly. So here in the ICP crisis, it's extremely important to maintain the mean arterial pressure or systolic pressure, whatever you're targeting. MAP is fair enough, considering you don't have ICP monitor right now. Right.
Yeah,
Okay.
just the 11th edition, if you all have you all read the 11th edition, the newer guidelines? Because since you're presenting it, you should be knowing it. So when you do the primary survey, now it has changed from ABC to XABCD. And because Dr. Shafi rightly asked you about the blood pressure, and you all identified hemorrhagic shock as one of the main criteria, you don't need hypotension to diagnose grade 2 shock, right? Only after grade 2 would hypotension actually occur. So there would be a narrow pulse pressure. So this case, you need to say we did the X, ABCD. X stands for any exsanguinating injuries on the extremities, etc. So that should be a newer algorithm. And then, unfortunately, or whatever, the newer guidelines do not give you any chapter on traumatic brain injury separate. They have put it as traumatic brain injury and spine injury in the disability chapter. So, as you rightly mentioned, the systolic blood pressure should be maintained at 100 and the mean should be maintained at 80 in a head injury. Okay. And for spinal cord also, you should maintain a map of 90. So they have given much more importance now to the spine along with the brain. Sorry for interrupting you, but the newer guidelines have to be quoted and you have to say X. You have to also say, like you said, intubated during the airway. You should have said that we gave 1 liter fluids and we cross-matched blood. Because this hypotension could have been part of your hemorrhagic shock as well. Yeah, go on.
We are coming to secondary survey, sir. Secondary survey, like it includes like 5 components, like any history of allergies, any medication histories, and patient has no documented allergies and no medication history. Patient is like no nil coma and last meal also we don't know, and like events like not significant as much as like as the bystander said, sir. So head to toe examination.
Any medication history is very important here.
Yeah, sir. Like if patient is on any anticoagulants and antiplatelets, like bleeding risk will be more high.
Very important. So you need an anticoagulation antidote chart here. And one more thing that he may be drinking and driving. So alcohol intoxication.
Yeah.
So specifically mentioned, see, this is from the book, ample history, this history. But to your case, you should always point out important things. Like you said, anticoagulation, like you said, alcoholism. Okay, please go on.
So head-to-toe examination was found to be like abrasions, mainly sustained right side of the body. So like abrasions on right forehead was found, laceration around right upper lid, right eye ecchymosis, and swelling was present over the occipital region. Log roll was negative, and like facial multiple aberrations were there over right, left zygoma regions. Chest, abdomen, bladder, and bowel, no abnormality detected. Musculoskeletal, multiple aberrations are over right ankle, left leg, and like left torso. No major long bone injuries were suspected, sir.
Anything you want to elaborate on this slide? Just one thing.
Sir, log roll.
No, you are not. Log roll happens only after stabilization. Your patient is not yet stable. Anything that you want to elaborate? Right eye ecchymosis. Do you want to say something about it? Ecchymosis within the eye or around the eye or raccoon's eye?
Around the eye, sir. Ecchymosis was found around the eye.
So that is raccoon's eye, right?
Yes, sir, raccoon's eye, which
so then what does it indicate? What does it indicate?
Anterior cranial fossa injury, sir. So it will be suspected.
Basal fracture, skull.
Yes, sir, basal fracture.
Yeah. And along with it, you would have probably, what are other signs that you may suspect basal fracture?
Sir, CSF rhinorrhea, nasal discharges.
Okay. Yeah.
Discharges we can be suspected.
And battle sign.
Yes, sir, battle.
Okay, good. So never let this pass off because it's important. And what would you not do when you suspect basal fracture?
Sir, I will never try to put any intervention through nose
Yes.
cells or virus tube
Yeah,
something. I
very
will
good.
never do that,
Excellent.
sir.
Yeah, please move.
So this is a CT scan of the patient. So preliminary report was
One thing, doctor, sorry to interrupt. So before, as a part of the secondary survey and before transferring the patient for the CT, did you do the fast examination in this patient or e-fast?
yeah, yeah, sir, yeah. I will
So
like to
not
do it.
mentioned actually. Do you think it's important or not in this case?
It's important, sir. It's important. We have like mentioned later.
So what was the finding in e-fast examination? Because your
EFAS was
patient
found
had
to be,
hypotension.
yeah, sir. EFAS was found to be negative, sir.
Okay.
Splenorenal, hepatorenal diseases were like not reached, and bilateral hemorrhages was there is no found of no pyotactic.
It's okay. I think if you just said e-fast is negative, so we can understand from that. Yes. So sometimes examiners can simply ask you about what are the components of the e-fast. I'm sure you can elaborate about that. So so what are the components of extended fast?
So extended fast includes like bilateral chest regions and unlike a suprapubic assessment, sir.
What are the different areas in which you scan for the fast e-fast examination of fast?
Subsified right upper quadrant or
Okay.
left upper quadrant, pelvic region, right chest and the left chest region.
Very good. Very good. Extremely. So that as any part of the trauma, particularly in high kinetic injury or high impact injuries, extremely important to do the fast examination as a part of the secondary survey. Okay. Yeah. Move to the next slide, please.
CT CT scan was done and it showed acute right frontotemporoparietal SDH with midline shift with effacement of sulcal spaces, and there is cerebral edema present in the CT scan.
Okay.
So how would you differentiate a subdural from an extradural on a CT scan and even clinically?
So extradural hemorrhage on CT scan will be of lenticular shape, and subdural hemorrhage will be of crescent shape. Clinically, ED extradural hemorrhage will have a lucid interval during which the patient will be conscious initially after the injury, and then
conscious, then again
conscious. And because of the expanding hematoma, because of the artery rupture, then the patient becomes unconscious.
So any lucid interval history would make you call somebody, your friend, your senior, Dr. Venkat, or somebody else.
Neurosurgeon.
Who should you call immediately?
Neurosurgeon.
Yeah, absolutely. Why? Because it's an emergency. Very good. Yeah. So that is the second part. What are the other differences? Subdural and extradural. One is the shape. Second.
And then the extradural hemorrhage will not cross the suture line or the midline, but the SDH can cross.
Yeah.
So
which is more of an emergency? Which is more of an emergency?
Extradural hemorrhage is an emergency.
Why?
Because it's an artery rupture.
Very good. Which one? Which artery?
Sorry.
Just complete it so I don't have to ask you. Yeah?
Middle meningeal artery, sir. Middle meningeal artery.
Wonderful, wonderful. Yeah. So, and whereas this is venous. Yeah.
Yes, sir. Bridging vein.
What? Anything else? Anything else? So a subdural is more towards the brain and therefore the morbidity is higher. Whereas the extradural is more towards the skull, so may be associated with a fracture bone. But those are not important. Yeah.
Okay.
Go ahead. Sorry, Shafi? Yeah.
Yeah. So I was just telling exactly, you described about the size actually, but what is the thickness of SDH and what was the midline shift, exactly the number? Do you think is there any importance for this?
Yeah, sir. Midline shift was around like more than 5 mm, sir, and like the density of the volume was more than 25. So that's why like Marshall grade became like 4, sir. We are given like Marshall grade 4.
Right. So the Marshall grade 4 with significant cerebral edema is present, and patient's GCS is, I think, 8, right?
Yeah, sir. Yeah.
Okay. All right. Yeah. Next.
So initial treatment, like we have resuscitated the patient with IV fluids, injection tranexamic acid 1 gram given, or in minutes, injection Levipil given.
Okay, so
Yeah.
1 minute. Yeah, sorry. So tranexamic acid you have given on 10 minutes. So what is the role of tranexamic acid here and why we are giving it?
Sir, tranexamic acid, like we are giving, like according to CRASH 3 trial, they have studied tranexamic acid 1 gram over like
What
10
is
minutes.
tranexamic acid actually? Which group of
Sir, it's
medicine is this?
antifibrinolytic agent, sir.
Okay.
It's antifibrinolytic. Yes.
Okay, fine. So why we give it exactly?
Sir, to like stop bleeding and all, sir. So CRASH 3 trials explains that from tranexamic acid, role of tranexamic acid less than 3 hours, as soon as the patient arrived, like shows better outcome with mild and moderate TBI, sir, but not in severe TBI.
Right.
Yes.
So this patient has a severe TBI.
Yeah, sir. Yeah.
So what was the role of tranexamic acid then? Yeah, it's very important, as you said very nicely, that in CRASH 3 trial, tranexamic acid was, overall, there was no difference in the outcome, but in the mild to moderate group, it was significantly associated with improve in the 6-month outcome actually. And in severe TBI, it was not associated with improvement in outcome, but overall, it was very safe. There was no safety concern. There was no increase in thromboembolic event actually. So that's why it is safe. So it is fair enough. You can give it, but I think it's good that you know the rationale behind that. Very good.
Very nice. Yeah. And people always ask about tranexamic acid, so you should know everything. The latest, again, 11th edition guidelines have said that you give 2 grams immediately, and that is within 3 hours. And then you give 1 gram later after 8 hours. So they've just changed a little, and they have also included severe in these cases. Okay, there is no harm, as Dr. Shafi said. So, yeah, good. Please go on.
Anti-seizure prophylaxis was given in the levetiracetam 1 gram was given.
So is it to be given in every head injury, and if to be given which group and how long? Anti-epileptics.
Anti-epileptics, there is there is a recommendation for only early onset seizure prophylaxis are less than 7 days in traumatic brain injury.
Excellent.
There is no role for anti-seizure prophylaxis post 7 days in case of a traumatic brain injury.
And there's no indication in this patient to be given also. Only if there is any seizure or fracture of the skull, then only you should give it. Otherwise, no need to give anti-epileptics upfront.
Okay.
But good,
Okay.
7 days is the catch. Go ahead.
Okay, and what was the reason of choosing Levipil? Is there any advantage of using Levipil over any other anti-seizure medications?
Yeah, sir, like less enzyme inhibition, less interaction with the multiple drugs.
Okay. Very good. Anything related to efficacy? Levetiracetam is better on phenytoin or valproate or anything? Efficacy wise, is there any difference?
Efficacy, mode of time of action.
Yeah.
Sir, it takes action of mode of action within approximately 5 to 10 minutes, 10 to 15 minutes, sir. So that's why we are preferring Levipil and less interaction with other drugs, sir. And that is the main thing, sir.
You're right. Yeah, you're absolutely right. Actually speaking, the efficacy wise, there is no difference between these 3 classes of the drugs actually. So efficacy wise, they are same, either in a status epilepticus or in the head injury. But the latest Neurocritical Care Society's guidelines says levetiracetam is slightly better because of its safety profile and interaction, as you said. That's fine. Brain Trauma Foundation guideline doesn't specify any one over another. Right. Yeah, so, please move on.
Yeah. Then injection mannitol was start given, followed by injection 3% in NaCl was given, followed by infusion started and patient shifted to ICU.
So is there any recommendation for both?
Yeah, that's what I was asking. Yes, please.
Usually we don't give both, right?
Oh, can you explain why you have given both of them? Any particular reason, or it's just it was given initially by the ER guys and then it was continued?
Initially, it was given by the ER people, sir, mannitol.
Okay.
And they started on 3% NaCl also, and like with infusion, the patient we received the patient with infusion, so 3% infusion. As like
Okay. All.
So this is your case, so you have to answer it
Explain.
as you have done. You cannot say ER
Exactly.
gave it and others gave it. We may sometimes put words in your mouth. Right. Anyways, there you need to discuss between mannitol and 3%. Now, going back to your CT scan, and if the patient we don't know on the field had a Glasgow coma of say 9, and now he's got 7 and this kind of a midline shift. What is it called in the, again, as per the newer edition, it's called as a critical neuroworsening. So would you need to, so since we asked you about mannitol, would you want to elaborate? What do you do till the neurosurgeon says that I have half an hour to take the patient for evacuation? Till then, what do you do in this patient with this midline shift? So what are the things that you do? And what are the drugs that you do? What interventions would you do till that half an hour so that he doesn't deteriorate further and reaches the OT in the same condition as he is now? Did you get my question?
Gold directed parameters like will be like maintaining saturation of more than SpO2 of more than 95 with PaO2 of 85 to 100 with PCO2 of 35 to 45 normocapnia.
So all this you are doing, my friend, as a prevention of secondary hit. But this is an acute deterioration in this patient with a midline shift, and the patient is going to OT in the next half an hour. As I can see, neurosurgery surgeon is ready. What are you doing as an intensivist for this half an hour? Has it something to do with whatever you just discussed?
We have to maintain ICP, sir.
Yeah, how would you do that? You have to prevent it from rising.
Yeah, sir. So we'll start.
Hyperventilate the patient and give bolus dose of mannitol, 1 to 1.5 gram per kg bolus we will give, and then maintain MAP around 80 to 100 mmHg. And also we'll start sedation and analgesia with fentanyl infusion, and also we'll try to maintain the temperature, analgesia, and glucose levels, and anti-epileptic medications to be continued.
Yeah.
And we'll,
So this is one case where you might need to do a transient controlled hyperventilation, get the CO2 down till 30 to 32, not too much, 28 to 32, and you might give mannitol. So 100 is not enough. You need to give 300 as per the 1 milligram per kg dose. And you would have to give 300 mils of mannitol, 20%, and you need to take the patient to the OT. So these are the two interventions you might do. There might be a Cushing's reflex also, which is very, very dangerous. And hyperosmolar therapy is indicated here. Otherwise, don't say both mannitol and saline.
Okay, sir.
Okay, so as Dr. Pushkar was nicely pointed out, the most important thing in this patient, this is the only indication for hyperventilation in traumatic brain injury in first 48 hours, right? First 24 hours to be precise. When the patient is herniating, this patient was clearly herniating at this time. So the hyperventilation to a PCO2 of 30 is absolutely necessary and for a very short period of time. So what happens when in TBI patient, when we hyperventilate for a longer duration of the time?
There will be hyperventilation-induced vasoconstriction leading to ischemia of the brain, leading to aggravated secondary brain injury. And,
okay, very good.
And we need to avoid hyperventilation also.
Right. So normally, as you clearly pointed out, we try to maintain normocapnia, but in acute situation for a brief period of time, we can do control hyperventilation to a PCO2 of 30, but not below that. Yeah. So and second thing is, as we were discussing about the hyperosmolar therapies, so it's very important to know the differences between the mannitol and 3% saline. So what are the recent guidelines and the recent meta-analysis says about which one is better, or both of them are equal in terms of efficacy and side effect?
Sir, comparing mannitol and hypertonic saline. So mannitol, like osmotic diuresis, like it helps in like volume depletion, sir. So but hyperosmolar therapy helps in like volume expansion, which helps to maintain a blood pressure. But In mannitol, there is a risk of hypotension due to diuresis, which may even more worsen the cerebral perfusion pressure, sir. So we'll be taking consideration like renal parameters while giving mannitol, and hypotension, either shock or hypotension is coming into picture. So we'll decide according to the clinical parameters of the patient presentation, sir.
Yeah, very good. So the most of the evidence is now, and the latest Neurocritical Care Society's guideline also pointing towards that we should try to move more towards the 3% saline or hypertonic saline, any one of them, because of efficacy-wise it is better. And second, as we said in this case, the patient was already hypotensive, and with mannitol can cause hypotension because of diuresis, and which can further decrease the CPP. So the 3% is better in this case. You can use as a bolus or an infusion in both form actually. So that's the point. So when you're using the 3% saline, what things you're gonna monitor in this case?
Sir, serum osmolality, sir. So serum osmolality targets will be it should be less than 320, with serum sodium level around 145 to 155 target will be there. So we can maintain according to that, sir. These are the parameters, and osmolar gap should be less than 20 while we are giving a hypertonic saline therapy, sir. Hypertonic saline therapy. These are the things that we consider.
Okay, very good. So other thing will be with the mannitol is because of mannitol coefficient, it is less retained in the intravascular and can leak inside the brain tissue compared to the 3% saline. So the theoretical risk of causing paradoxical increase in ICP with mannitol. This is one which is less with the 3% saline. Right. Thanks. Yeah. So next we can move to the next one. Yeah, you're coming to the consultations. Yes.
Sir.
The consultations taken were neurosurgery for they advised SOS, DECRA, and plastic surgery for stabilization, and orthopedics and critical care department consultations were taken.
Very good. So one thing here, your patient has a severe traumatic brain injury with initial GCS of I think 5, and you have Marshall grade 4 in the CT with significant midline shift. So why this patient was not taken to the OR immediately?
Sir, patient was sir, we have to resuscitate the patient because little hypotensive side. First, we have to resuscitate the patient. We have to reserve the blood products for any anticipated blood loss during surgery. So for that, unlike CT scan, interval between the CT scan. So these things made us they told neurosurgeon will be taking DECRA SOS basis, sir.
Yeah, so do you think this is the right decision? Yeah, Dr.
No, absolutely right. So both have to come simultaneously. The surgeon needs some time to, prepare the OT, and therefore you need to stabilize the patient. So it goes simultaneously, hand in hand. When you do any intervention like IV fluids, intubation, always mention what was the blood pressure before and after. As Dr. Shafi had asked you in the beginning, what was the BP before and after intubation, before and after sedation, before and after IV fluids. So by now the BP must have been better, I hope. And systolic blood pressure was maintained at say 120, the oxygenation was being maintained, and all precautions were taken to shift the patient to the OT. So SOS, you should not be saying, you should say, we spoke to the neurosurgeon and we expressed our need for urgency, and we finally, they are a different breed, so you have to follow what they do, but then we have to keep trying.
Okay.
Sorry, Shafi, you were mentioning something.
Yeah, no, the same thing I was just trying to tell them regarding what do you think was this patient should have been taken to OR immediately, because while you were stabilizing the patient, and I'm sure patient was stabilized before shifting to the ICU. So was it the decision was correct, or you should have gone to the OR directly from the ER?
Sir, patient should have been went to OR, sir. OR immediately, from the ER.
After intubating and stabilizing. So that's what you have been doing. Yeah. You cannot send somebody with a low blood pressure to the OR, right? So You have to intubate, you have to maintain the blood pressure, maintain the oxygenation. See, remember, there are many H's which cause secondary hit to the brain, already hit brain. And that may be hypercarbia, hypocarbia, hypothermia, and so much more. But what is important is hypotension and hypoxia. So even transient hypotension for just a few seconds to a minute can cause 50% increase in the mortality. And hypoxia, again transient, can cause 25% increase in the mortality. So hypotension and hypoxia together is very, very detrimental in even if transiently it happens in a traumatic brain injury. So extremely important. Hmm? And something they have added now in the 11th edition, they've said that once intubated, pay a lot of attention to sedation and analgesia. So many a times we worry about the neuro status because of that we don't give sedation, but they say you can reduce the ICP after intubation with a lot of analgesia and sedation. And sometimes, because they have amalgamated traumatic brain injury with spine, they are also talking of neurogenic shock. So you might want to just mention that there was no spinal injury and there was no neurogenic shock.
Okay.
Sorry, go ahead. Yeah. Is that over? The case is over?
Still.
Go on, please. Yeah.
So like post-intubation X-ray we have taken.
Okay.
Day 2 of ventilation. Patient is like continued mechanically ventilation, and ABG was found to be respiratory alkalosis, and pulse was around 72 and BP was around 115 by 73, SpO was 100 and respiratory rate was 24, and patient was found to be afebrile. Urine output was adequate. GCS was found to be E2, VT and M5. Bilateral pupils like 3 mm reacting to light, and we did optic nerve sheath diameter was found to be having 0.56 centimeter, and no abnormalities were found in the labs. Patient continued hypoosmolar therapy and started on RT-FITS and DVT prophylaxis was given. So,
would you give this patient antibiotics? Prophylactic antibiotics?
Sir, we should start, sir. We have given on a...
Why would you? I would not. Any recommendation? No, na?
No, sir.
So the act of intubation, the act of trauma without any scalp injury, which is contaminated, there's no need. Huh? So every question doesn't need a positive answer. Huh? Some examiners always like to ask. So you're answering beautifully. I love the flow, both of you all. But no role for antibiotics here.
Okay.
Regarding antibiotic, I just would like to add one point here. That antibiotic as such has no role for the traumatic brain injury per se, particularly the closed head injuries. But the recommendation is to use a single dose ceftriaxone to prevent episode of VAP in these patients.
Yes, yeah.
But that is one dose of ceftriaxone, that is enough. The recently published 2024 trial. And if so, decreases the duration of mechanical ventilation and length of ICU stay. So
that was
intubated,
one study,
yeah.
One study, Shafi, yeah.
Yeah. So this is only for one dose for antibiotics, not for continuing antibiotic therapy, actually. That's okay. Thank you.
And ONSD, which was plus minus in traumatic brain injury, has again found a resurgence as per the new guidelines. So they recommend you can always do the ONSD if you are capable of doing.
Okay, doctors, Dr. Kiran and Karthik, you have managed the patient very beautifully, intubated, ventilated, stabilized the patient, and day 2 of the patient is already there. And what thing, according to you, is missing in the patient's management? The neurosurgeon is taking his time. He wants to wait for the operative intervention. You have done everything in this patient. But there's something which is one of the most important thing according to the Brain Trauma Foundation guideline, which is exactly so ICP monitoring here. So what is the indication of ICP monitoring according to the BTF guideline?
Sir, according to BTF guidelines, like ICP monitor, like ICP should be kept below 22, sir, 22 mmHg.
No, when indications.
GCS less than or equal to 8 and significant anisocoria and unilateral, bilateral, fixed and dilated pupils or presence of seizures or any significant midline shift in the CT scan are the indications for the ICP monitoring, and it should be kept less than 22 mmHg.
The indication, as you rightly pointed out, any patient with a GCS of is less than 8, equal to 8, or if the GCS is more than 8, then either the patient's age is more than 40 or patient has unilateral or bilateral motor posturing, right? This is an indication. So according to you, this patient, ICP monitoring was indicated or not?
Yes, sir, it was indicated.
And
Okay,
one more
so
thing, any drop in the GCS by 2, even if it was 13, and it has dropped by 2 or 3 after resuscitation, that means there is a problem. So you start monitoring.
So what if suppose I gave you an option of monitoring the ICP in this patient and you can do in that? What are options of ICP monitoring? Which one you would like to use in this patient?
Sir, ICP monitoring involving like invasive, non-invasive, both two methods are there, invasive, non-invasive.
Very good.
Non-invasive like will be going towards like optic nerve sheath diameter, and there are options like a transcranial Doppler and pupillary. Invasive comes around like external ventricular drainage and like therapeutic lumbar puncture, sir, lumbar puncture, and like we have like
1 minute. So you said first external ventricular drain or EVD, right?
EVD.
So which one you will prefer in this particular patient? EVD will be preferred or any other method will be preferred?
EVD will be preferred, sir.
Why?
Sir,
very good.
CSF can be like removed for sample. CSF therapeutic CSF removal can be done.
Very good.
Like,
okay, so first is this is the gold standard.
ICP
EVD is the gold standard. Yeah. The second is that you can do a therapeutic drainage of the CSF continuously.
Sampling can do.
Okay. So, and what are the problems with this type of EVD? Is there any disadvantage of using EVD?
Infection rate is high, and there will be
very good.
malposition and occlusion of the catheter, and any infections like meningitis risk will be more, and also the technical difficulty will be more when compared to the intraparenchymal catheters.
Excellent. Very good. Very nice. Fine. Okay. So what are the other methods of EVD? You say one is EVD. Another one, which is also commonly used in ICU?
Intraparenchymal and
subdural devices we can be placed, and intraparenchymal devices also you can be placed.
So intraparenchymal is the one because it can be done at the bedside if you just need some small bud hole and you put inside the brain tissue itself. So what are the advantages and what are the disadvantages of this method?
Ease of keeping the catheter is more, and also it is
lesser rate of infections than EVD. And,
exactly. Very good.
It can be used in less resource settings, limited resource settings. We can use intraparenchymal catheters.
Yeah. So the advantage is this is the one which is a disadvantage of EVD, so infection, hemorrhage, etc. And the disadvantage is again that you cannot drain CSF. It's only can be used for monitoring. Exactly. Okay. You're telling something about the epidural catheter. So is the epidural or lumbar catheter is used for head injury or not?
Not
for
used.
CSF drainage.
Not recommended.
Yeah, because the risk of herniation is very high. This is mainly used. Yeah, this is mainly used for subarachnoid hemorrhage, the lumbar drain, and not used for the traumatic brain injury. Right.
Any other non-invasive technique you know of, even if you haven't used for ICP?
So we can monitor the saturation of jugular venous oxygen.
Okay, but that becomes minimally invasive. Yeah.
Sir, we'll go with the TCD, transcranial Doppler, pupillometry.
Very good.
Very good.
Yes. Multimodal monitoring and fiber optic just for ICP. Fiber optic Camino's scope. Yeah. Okay. Move on, please. I think we have just 10 minutes more to complete. So, yeah.
Sure.
On day 3, patient is continued on mechanically ventilated with IBC showing respiratory alkalosis. And there was an episode of pulse rate was found to be 60 with BP was 165, but the saturation was maintained. Afebrile, urinary outflow fatigue. There is a drop in GCS, E1, VT, M4. Pupillary anisocoria was found to be having, but pupil was sluggishly reacted to light. ONSD was found to be increased with 0.67 centimeter, And repeat CT we did, which shows interval increase in subdural hemorrhage with midline shift. So labs were found to be no abnormality. We have continued on hyperosmolar therapy. Neurosurgery review was taken and patient shifted to OT for right frontotemporal decompressive craniotomy, sir.
Neurosurgeon came back from his holiday, I guess. Yeah.
So one thing here. So you said you hyperventilated the patient, right? For the brief period of time because your CpCO2 decreased for 28. So during this episode, like from day 1 to day 3, were you stopping sedation in this patient daily or what you were doing? How did you assess the GCS? After stopping sedation or before stopping sedation?
Sir, after stopping sedation only.
So do you think it's a fair idea in a patient of traumatic brain injury in first 48 hours? Should you stop sedation for this patient?
No, sir, no. Basically, like it comes, sedation comes on a tier 1 or 2 management of ICP. So sedating the patient will keep him like ICP will be like in the lower range, sir.
Yeah, so that's what I was trying to say because in the day 1 also you sedate, 2 also you said the patient GCS is M5. On sedation, we cannot say the GCS. When the patient is already sedated, deeply sedated, you say what is the RAS target in this patient? RAS was -2, -3 or RAS was -4, -5. Because our aim is to keep them deeply sedated. So how you can stop sedation and assess the GCS, isn't it?
Yes, sir.
Okay. And the patient developed
there may be other
anisocoria.
signs of deterioration, like there may be tachycardia, hypotension, and then you have to even think of VAP or other parameters. But your CT scan definitely showed an increase. So that's fine. But you have to rule out other causes also of deterioration on day 3. So it's not always a neurodeterioration. Yeah. Good. Yeah.
So one more thing. Can you go back? Can you back a little, please? Yeah. So you are monitoring the ONSD was elevated in day 2 also, right? At that time also, neurosurgeon did not, and you did not repeat any CT on day 2? Normally, we repeat a CT scan after 24 hours, actually.
Yeah.
It's not a guideline based, but to see the increase because it was repeated on day 3.
I think they repeated when the neuro deterioration happened, according to them.
Happened, yeah, on day 3. Yeah.
Fair enough. Yeah.
Right. So, so do you think in this patient could have directly gone for OR without going for the CT? Was repeat CT was necessary in this case? Since there's a clearly a neurological deterioration in this patient with features suggestive of raised ICP.
There is no recommendation to take for repeat CT if clinically patient deteriorated, sir. So he can be taken up to OT OR without any radiology investigation.
Fine enough. Fine. So the patient was taken to OR, right? So they did a right frontotemporal decompressive craniectomy, right?
Yeah.
Any hematoma evacuation was done or not?
Yes, sir.
Yeah. Okay. All right.
Yeah. Move on. No.
This was the ONSD picture, which was showing, sir, like with the right eye we did.
Yeah.
Day 4, like it's post-operative day 1. Patient was continuing on mechanical ventilation, sedated and paralyzed. Here, during this also, ABG showed respiratory alkalosis.
So don't use the word paralyzed. We do not use it usually. I know we do it on rounds also, but was given muscle relaxants.
Okay.
Yeah.
So vitally, patient was found to be like stable, neural output was adequate, and GCS was found to be 2VT and M5. Pupils were 3 mm and 2.5 mm. Both were reacting to light. Labs were found to be no abnormality, and like patient was continued on hyperosmolar therapy and supportive care, sir, as per the IC protocol.
Yeah. Besides the multimodal monitoring, can we go back? Yeah. What else do you monitor when somebody is on a muscle relaxant? You may be giving too much of it, too little of it. So anything that you monitor, it's called as the TOF, that is strain of 4. So you need to keep that between 1 and 2.
Yes.
Okay, go ahead, please.
So these are the parameters of day 5, 6, and 7 comparatively. And like GCS were found to be the same, so E2 and M5 component around 7 to 8. Pupils were reacting light. Hemoglobin was maintained and TLC was within normal limits. And sodium was also at normal limits. Like only one day we got around 147. ABU was found to be like mixed alcoholic disorder on the same, like on the all the mechanically ventilated day. And day 7, we preferred as patient, we did tracheostomy to the patient in view of weaning and low GCS, sir. Patient was tracheostomy on the day 7, sir.
Okay. So one thing, can you go back? Yeah. So one thing I would like to point, your patient sodium was always on the lower side actually. Not in the, despite of 3% saline infusion, he never reached the target actually. Only on day 6 he reached 147 again. He did, were you continuing 3% saline infusion all the time?
Yes, sir. Yes.
So, but you are not in the target, isn't it?
Yes.
Our target is 145 to 155
Yes.
at the most of the days.
Almost there, maybe.
Yeah, almost. Yeah, yeah. Fine. Right. So you did the tracheostomy on day 7. What was the reason of performing tracheostomy?
Sir, in view of like weaning and like low GCS, like we planned for tracheostomy, sir.
So your GCS was exactly how much on the day 7?
7. It was 7. It hasn't improved much. So long-term care. Yeah.
Right. So what the guideline says about doing early versus late tracheostomy related to traumatic brain injury?
Sir, early tracheostomy. Early tracheostomy.
How do you define early tracheostomy? Sorry, yeah.
Early tracheostomy is like
less than 72 hours and more than 72 hours, sir. And they did not find any.
72 hours.
5 to 6 days, sir. We'll be early tracheostomy like recommend 5 to 6th day of mechanically ventilated day. So if you do tracheostomy 5th or 6th day, it's called like early tracheostomy. There is no proven mortality benefit, but functional outcome and weaning was weaning weaning was found to be like little positive, sir, in the early case of early tracheostomy and to prevent VAP. So
yeah, very good. So in this particular case, since we are talking about traumatic brain injury, so the studies in general ICU patient did not show any difference in early versus late. And the thing what we discussed just now about the tracheostomy, the duration, timing is usually said early less than 7 days. Although a lot of the studies use different criteria, some were 10 days, some even 3-4 days, but by and large the consensus is 7 days. Before 7 days we call early and more than 7 days late. And pertaining to the neurosurgical patients, neurology patients and in traumatic brain injury, the early tracheostomy is associated with decreased duration of mechanical ventilation, decreased number of the days, and even decreased ICU length of stay. So this is one indication where the early tracheostomy is recommended if your patient cannot improve and cannot be extubated. Yeah, good.
Yeah, I think Kiran, we can finish the case now so that we can just take some questions of the or chats from them.
Okay.
Yeah. Anything else that you need to point out, or
this was a last day, day 8 and day 10th. Like the patient were weaned at the moment and tolerating well, and patient was shifted out to O2 room with further physiotherapy and supportive care, sir.
Yeah, sure. And the Glasgow coma improved just a wee bit.
Yeah, sir. Yes.
Yeah. What is the new Glasgow coma scale? I mean, just splitting hair, but so they've added NT, non-testable in all 3. Okay, so you should just be aware. I think it's our duty to answer all the comments and questions. So the Ramakrishna has written mannitol to be given an EDH or SDH as it will shrink and cause expansion of the bleed. So nowadays we don't use much mannitol, but hypertonic may be used so that this doesn't happen. And it should be given mainly only after stabilization and getting the blood pressure right and the oxygen right. And as we discussed, when the patient is coning or herniating, that is the time when we would probably use the higher dose. Hyperventilation, again, only transiently and during that. COBE trial has been mentioned. So yes, that was a trial where 20% hypertonic was used. We are using only 3% here. So we cannot extrapolate that study. And there also, it did not show much of a difference between mannitol versus hypertonic. Dr. Khan has said neutral head position. Sorry, I'm going too fast here.
Yeah.
Neutral. Yeah, can you?
Yes, sir. The questions that some of the attendees have asked is about role of steroid. That's
Okay.
the debate that has
Okay.
died long time
Yeah.
back. I don't
Yeah.
think
Can I
there is
answer?
any role of steroid.
Can I answer?
Yes, please, Shafi.
Yeah. So the role of the steroid actually, it was long term back, as you nicely pointed out. A lot of debate was going on, but the big randomized control trial, which was a crash, the first crash trial, actually recruited a lot of patients in this, almost 1,000 patients, and found that at the day 7 and 8 there is the worsening of the neurological status in a steroid group. So it is clearly contraindicated in hereditary patient.
Yeah.
Yes. And
Yeah,
one
Karthik, you
question.
can tell us all the questions so that, yeah.
Yes, yes, sir. And one attendee wanted to know about subgaleal hemorrhage and how do you address it? Probably in pediatrics, probably he's referring to, I'm not sure. So,
So
yeah,
subgaleal hematoma is
yeah,
basically an area where it can really bleed a lot. And if there is a gash or a contusion, then there is a lot of bleeding because scalp is the most vascular structure in the body. So you need to take care of it, but it has no consequence on the traumatic brain injury. So it may look like
yes,
a big bump, but it doesn't
Yeah.
cause any problems. But you need to see for any underlying fracture of the skull or any other extradural, subdural, along with it in the CT scan.
yeah. And there was one question regarding the decompression craniectomy, like what is the size and what is the indication for decompression craniectomy?
Yeah.
Yeah.
Yeah. So,
From your Kiran and
Yeah,
Karthik.
sure.
yeah.
Yeah, yeah.
So regarding decompressive
You
craniectomy,
want a big,
yeah. So regarding
yes,
decompressive craniectomy, basically it is two types. One is the primary decompressive craniectomy and the secondary decompressive craniectomy. The primary decompressive craniectomy is the one in which, as a part of hematoma evacuation, you do decompressive craniectomy. The secondary decompressive craniectomy is when you are not able to control the ICP despite of the maximum measures, and you do a decompressive craniectomy. So what happened in the DECRA trial, as a decompressive craniectomy was done, as like a in which you already ruled out there is no hematoma, and you did only 4 days ICP. They did a big bifrontal decompressive hemicraniectomy. So later on, they said they saw that patient has a lot of complication like CSF leak and wound infection, etc. So now the trend is towards doing unilateral decompressive craniectomy, but the decompressive craniectomy should be enough to decompress the brain. So normally they're usually unilateral and to a frontoparieto-temporal enough to expand the brain. But usually the bifrontal is nowadays, bilateral is usually avoided. So I hope this answers the question.
yes. So even the BTF says that bilateral is to be avoided, single-sided, and 12 by 15 or a diameter of 15 centimeters is what
More than 15 will be like adequate.
Yeah,
yeah,
exactly.
more than adequate. Yes. So we have completed most of the questions. How reliable is GCS in intoxicated patients or
I'm
polytrauma?
sorry. The RESUS ICP and the DECRA are the two studies which have studied this craniectomy. And unfortunately, it has not shown much of a difference in the mortality, but it has said that you keep them alive longer and therefore the morbidity is terrible. So,
Yes.
unfortunately, there is not much data, but we have seen patients walking home, even young patients with traumatic brain injury, even after 6 months, if a craniectomy is done appropriately and on time. So, that's just an expert opinion, but as per study, you can always argue it out. Then these are the two studies, and there are more in the pipeline.
Okay, just one theoretical question for our friends regarding the last. How do you prognosticate these patients? Or basically, I would like to give a comment on this, that prognostication of the head injury patients should not be done early, because most of these patients are young and they have a very good prognosis. Even with the time, patient will be looking like he's dying, but later on, with time, he will improve. So at least before 2 weeks, there is no point of doing any prognostication in these patients, even if the GCS is like very low initially, unless until the patient is clearly brain dead. That's a different thing. So
And
otherwise,
if
don't
this, yeah.
prognosticate himself.
And one more thing, if this patient remains Glasgow coma 5 and below, despite all measures, what is the next step you would do?
Sir, I will like express my goals of care with the family and regarding that, sir. So
No, one is palliative, but the next thing which is recommended after post CPR and post trauma is transplant guidelines. So you might, this is a candidate who might be useful for a transplant because Glasgow coma 5 can become 3 anytime, and that's
Yeah.
when you have to get started with. Yeah. Okay. Dr. Venkat wants to ask something. He's raised his hand. Yeah, Dr. Venkat, it's your show. You
I
don't have
think
to raise your hand. You can just talk.
I
Yeah.
think yeah, sure. I think, sir, he wants to like in the panelist. Probably he's there. I think so.
Yeah.
He's trying to get in, sir.
Ah.
So I think we have completed most of the questions, sir. Only thing is, how reliable is the GCS in intoxicated patient polytrauma? We already discussed in polytrauma. Usually, I think the attendee wanted to ask in patients who are under alcohol intoxication coming with traumatic brain injury, how do you assess? But it's very difficult. It's a case-to-base scenario, and GCS cannot be clearly assessed in those scenarios. Probably patient would be in withdrawal. So there's no clear-cut answer to that. So I think there are no more further questions, sir, in the chat. And one of the attendee wanted to say that you never paralyze and try to keep patients conscious so that you rule out convulsions or non-convulsive seizures, which probably is not recommended according to the guidelines. As far as ICP is raised, you have to have measures to reduce your ICP. And rightfully, we had this discussion during the talk also that avoiding sedation breaks and assessing the sensorium should be minimized as far as possible. Only when patient's ICP is controlled, we can have the liberty to do that. And one more question is, what is the role of the osmotic agents post craniectomy? Yeah, this is an interesting question. Many neurophysicians and neurosurgeons still continue to give osmotic diuretics like mannitol or 3% NS post DECRA after relieving the ICP. When do you stop it?
So
That's one
basically,
question.
always avoid the extreme. So if there is hyponatremia, bring it up to 145, but don't have to continue the treatment. And mannitol, definitely no.
No. Yes, sir. Yes. Yes. So I
Dr.
think
Venkat
that,
wants to probably make a comment.
yes.
He was unmuted. Yeah.
Yeah, can
Dr.
you hear me?
Venkat, sir, you want to talk?
No, can you hear me?
Yeah, we
Yes,
can
sir.
now. Yes, Venkat.
Yeah. I think I thought I missed out that panel. I just was actually being a part of listening to the all conversation. I think most of the questions were answered. I wanted to just thank both of you for your participation and such a wonderful flow. You encouraged the students and also added so many insightful, valuable value addition. Thank you both of you for your points.
Thank you. Thank you, Venkat.
Thank you,
And
Venkat.
excellent. Students, very well done. You all have presented well and answered well too.
Thank you,
Keep it up. Yeah,
Yeah.
very nice.
Yeah.
thank you,
Yeah,
sir.
both of them were very nicely prepared and they
Yes.
knew most of the things, I think. So I congratulate both of you and all the best for your future endeavors.
Thank you. Thank you so much.
Great. Thank you.
Yeah.
Thank you.
So we'll close the session, sir. And
Sure.
thank you, Dr. Kushrao Bhajan, sir, and Dr. Muzammil Shafi, for having taken your valuable time out of your busy schedule and participating in today's webinar. I'm sure if you come as an examiner, we'll be taking out few questions from this webinar, and I think students will be benefited whenever they encounter you in the examination hall. And yeah, so we bring forth an interesting exam case scenarios for exam going students on every Tuesday in our masterclass session. And I would urge more and more students to take benefit of this program. And Dr. Venkatramana Kola and the team of Yashoda here have always been putting forth these masterclasses on every Tuesday. And it's been very beneficial. And the reviews that we hear after the class sessions are very encouraging. and especially our students find it very helpful, sir, with your insights like from our expert panelists today. So thank you all, and thank you, Dr. Karthik and Dr. Kiran, for taking your efforts and bringing this case presentation. And now you know where how you have to present your case, where you have to present the data in what way to the examiners, so that you get a better comments and better marks ultimately. Okay, so thank you all for joining, and thank you attendees for taking out their time. And we'll meet next Tuesday with another interesting topic. Thank you very much.
Thank you.
Thank you.
I thank Shafi. I thank Venkat for doing this forum, because it's much more interesting than a lecture. So thank you for having.
Definitely. That's a very nice concept, actually. It's an amazing concept.
Excellent. Excellent.
Yeah.
Thank you.
Thank you very much.
Thank you, sir. Thank you, sir.
Have a nice day. Yeah. Stay safe.
Thank you, sir.